As Dr. Basso said, this morning's topic is amyloidosis. And for this particular topic, I have no relevant financial relationships to disclose, and I won't be discussing any formal off-label usage of medications. Our learning objectives for this morning will be to define amyloid and describe various identification methods, and also to describe the various types of amyloid that are known to afflict the heart. In doing so, we'll also enumerate common typing methods and identify the preferred typing methods for figuring out what type of amyloid you're dealing with in the heart. So we'll start off providing a definition to level set, get everyone on the same page with what we're talking about when we use the word amyloid. Then we'll talk about how amyloid manifests both from a gross and histologic perspective in the heart. We'll talk about the types of amyloid and the nomenclature, and then we'll get into some of the details of the methodology that we use to type the amyloid. We'll talk about both direct and indirect methods, and then I'll have some concluding remarks at the end. So the term amyloid comes from the Latin meaning amylum, and this is because in the mid-19th century, when this substance was first recognized in human tissues by Virchow, he hypothesized that it was a starch-like chemical because of its propensity to react with crude iodine stains. It would take about 5 or 10 years after that to discover that indeed it's not a carbohydrate that we're dealing with in human tissues, but rather a proteinaceous substance. More specifically, it's the result of a misfolded extracellular protein. And the proteins that tend to deposit as amyloid have in common this kind of propensity or this ability to form anti-parallel beta-pleated sheets in their secondary structure, which allows them to achieve this very solid and stable configuration. The fibrils themselves are 7.5 to 10 nanometers in size, so smaller than that of collagen, and also unlike collagen, they're non-branching, rigid, and insoluble. Because of that beta-pleated sheet structure that I referred to just a moment ago, the material will bind an aniline dye known as Congo red and will birefringe with polarization. That feature became a feature that pathologists would exploit for the next 150 years to identify amyloid in tissues. It also exhibits a very characteristic cross beta diffraction on X-ray diffraction, again, owing to that important secondary structure. 31 recognized human proteins can deposit in tissue as amyloid. Now, these proteins deposit in tissues for a number of reasons. One of them is because the proteins themselves, in their normal wild-type form, can have an intrinsic propensity to misfold. That would be like transthyretin, shown here in the upper right. This tetrameric form of transthyretin has a high likelihood of achieving that beta-pleated sheet structure. When proteins have a natural tendency to form that, they can do so in response to aging as the proteins aggregate over time, or if the proteins are present in abnormally high concentration in the serum. Additionally, proteins can acquire mutations that change their amino acid sequence and make them more likely to achieve that beta-pleated sheet configuration. So mutations can also drive amyloid deposition in tissue. Proteolytic remodeling of the precursor protein, so basically not owing to a mutation, but again, a change in structure, typically imparted in the Golgi apparatus, which would then cause these proteins to fold in that way. There's also a notion of biophysical or functional amyloid. This is really more of a feature of invertebrates than it is of humans or other hominids or upper life forms. Things like jellyfish and the like can produce this substance as a means of protection. Under tissue, the amyloid substance appears as a very homogeneous, somewhat waxy, very solid character that usually insinuates itself in the extracellular space. The photomicrograph shown in the upper right here shows this very light pink material in contrast to the darker pink of myocytes here in the heart. And one of the things that you'll notice about this substance is that in addition to it being somewhat homogeneous and very uniform in nature, it has this interesting tendency to crack along the fibrils. And so you get these deep white cracks all throughout. This is very different than what we see with other extracellular substances like collagen, for instance. We mentioned that amyloid tends to stain with aniline dye, specifically the Congo red dye shown below in the lower right-hand photomicrograph. It'll impart a red character wherever the amyloid is depositing, but more importantly, when placed between cross-polarized light, that aniline dye will tend to fluoresce in an apple green type color, which is a very characteristic feature of amyloid. In addition to Congo red, other stains are also sometimes used to identify amyloid. Metachromatic dyes like crystal violet or methyl violet can sometimes be employed, as shown here in the lower right-hand photomicrograph. And then there's thioflavin T or sulfated Elsham blue, other stains that are very useful in identifying amyloid in tissue. Here at Mayo, we really like the sulfated Elsham blue stain, particularly when screening for amyloid in the heart, because it imparts a very easy to recognize seafoam green color wherever the amyloid is. So all this green substance is the amyloid aggregating in this myocardium. There's very little background material that cross-reacts with sulfated Elsham blue in the heart, which is why we like to use it. In the kidney, for instance, it's a little bit more of a problematic stain because the fluid in the tubules of the kidney tend to also stain with sulfated Elsham blue. But in the heart, we found it's quite specific, very technically easy to do, and of course doesn't require any polarization or anything like that to identify. What are the gross and histologic manifestations of amyloid? Well, as we already mentioned, amyloid, as it insinuates in the extracellular space, can impart a very firm or waxy character to the tissue. That firmness can manifest as very hard ventricles. And in fact, when amyloid is depositing in great amounts, it can sometimes impart a somewhat mottled appearance to the myocardium. You can see where the myocardium is lighter in certain regions, particularly here in the basal ventricular septum. That's where there's high concentrations of that amyloid. Because of the ventricular firmness that's imparted by the amyloid, it's not uncommon for the atria to become dilated as the ventricles are more difficult to fill during ventricular diastole. So again, that firmness that's imparting there is really causing the blood to back up into the atria and can sometimes lead to biatrial dilatation. Interestingly enough, there's a propensity that amyloid has to deposit in the basal ventricular wall, specifically the basal septum, as shown here. The reason for that is actually not known, but one of the consequences of that is specifically by way of imaging, one might see an increased septal to free wall ratio or disproportionate thickening of the septum beyond that of the free wall. And that is certainly a characteristic of amyloid as well as other diseases as well that we'll talk about in just a few minutes. In addition to depositing within the myocardium, amyloid can deposit on the endocardial surface, specifically the endocardium of valves, where it can impart a very sandpaper-like quality to the endocardium or somewhat gristly appearance to the endocardium. Some people have likened it to sandpaper as well. So instead of that nice smooth valvular surface, what we see here is a rough surface, almost like there's little dewdrops depositing on the valvular surface. You can see here on both of these atrioventricular valves shown that are quite extensively involved by amyloid. That amyloid can also extend to the endocardium proper beyond the valves, as shown here, and impart either a mottled appearance or a somewhat sandpaper texture to the endocardium itself. Now, we mentioned the propensity of amyloid to deposit in the ventricular septum, specifically the basal ventricular septum. That's shown here, where you can clearly see that there is an increased septal to free wall ratio. So this ventricular septum is thickened beyond that of the left ventricular free wall. And again, when one sees that increased septal to free wall ratio, amyloid would certainly enter into the differential. Now, of course, amyloid's not the only disease that can do this. Perhaps it's not even one of the most well-recognized diseases that can do this. Hypertrophic cardiomyopathy is well known for increasing that septal to free wall ratio or having this so-called asymmetric type of hypertrophy, as shown here in the left gross representation of four-chambered view showing that increased septal to free wall ratio. And another condition that we can see an increased septal to free wall ratio is referred to as age-related septal angulation, where there's geometric changes in the chest owing to age, and oftentimes underlying systemic hypertension that causes some degree of hypertrophy in the ventricle below, and then those geometric changes can result in anterior tipping of the aorta and produce a subaortic septal bulge that can make that septal to free wall ratio seemingly increase as well. So again, a number of diseases would be included in the differential diagnosis for asymmetric hypertrophy, but amyloid is certainly among them. Amyloid can deposit in tissues in a number of different patterns or morphologies. It can deposit in large nodules that seemingly replace the underlying myocardium. It can also insinuate itself in between the myocytes in a more delicate or pericellular type pattern, somewhat chicken wire or lace-like configuration. It can also deposit in the vasculature, in the small intramyocardial vessels. Interestingly enough, it tends to be pretty exclusive to these small intramyocardial vessels. It rarely involves the coronary arteries, and when it does, it's typically relegated to the vasa vasorum of the coronary arteries and does not involve the media or the endothelium of the coronary arteries themselves. So that's a somewhat curious feature of amyloid. It's important to recognize that vascular deposition when it does happen, because it can lead to anginal or ischemic symptoms in these individuals. And when they do an angiogram or put dye down the epicardial coronaries, they won't necessarily notice any discrete lesions in these individuals, again, because amyloid doesn't tend to involve those epicardial coronaries. Now, in addition to these morphologic patterns where the amyloid is depositing in somewhat different patterns in the myocardium, there are different types of amyloid that can look somewhat different than this more classical homogeneous appearing amyloid, and even types that involve the heart. Atrial natriuretic factor associated amyloid specifically has a somewhat different character to it, especially when stained with a sulfated Elsham blue stain. This photomicrograph here is an example that has two different types of amyloid involving the heart simultaneously. There's the classical type or transthyretin type of amyloid shown over here on the left. And then just adjacent to it is this pattern of amyloid, which looks a little bit different than this pattern shown over here on the left. It's more darkly staining, somewhat more heterogeneous. It has a more thread-like character to it, in fact, many more cracks than seen with this more homogeneous amyloid there. And indeed, on differential typing, these are two different types of amyloid that are depositing in this heart. This recognition of this phenomenon enabled us to study atrial natriuretic factor in its own right. And ask a lot of important questions about ANF type amyloid. Specifically, it's seen in about half of all atrial appendages that are resected during the Mays procedure. It's more common among women, and it does tend to be correlated with age. In fact, in individuals over the age of 80, the finding of atrial natriuretic factor related amyloid is nearly universal. Presence of amyloid does predict a higher likelihood of atrial fibrillation. However, that does not necessarily imply causality in any way, shape, or form. In fact, it's unclear whether or not the atrial fibrillation is causing the deposition of ANF-associated amyloid, or the opposite, whether ANF amyloid is actually leading to atrial fibrillation, or if there's some other underlying confounder or variable that tends to be riding with both. What are the various types of amyloid? Well, in the heart, there are about 8 types of amyloid that have been described. However, even though there have been 8 that have been described, about 98% of the amyloid discovered in the heart is accounted for by either light chains or transthyretin-associated amyloid. So those top 2 types there account for certainly the lion's share of amyloid seen in the heart. Despite the fact that light chain associated amyloid is believed to be more common from an epidemiologic standpoint, from a clinical standpoint, when we're looking by way of endomyocardial biopsy, transthyretin amyloid accounts for about 2/3 of the type of amyloid we see. Why this disconnect of AL amyloid being thought to be more common, but transthyretin amyloid being more frequently identified? Well, The light chain amyloids are simply identified oftentimes by other means other than endomyocardial biopsy. So the individuals are known to have myeloma, they have gammopathies with light chain ratios that are very clear, and then they demonstrate myocardial issues either by way of imaging or clinical history that lead the clinician to believe they have involvement of the heart, and the patient is never taken to biopsy. So that really explains the bias that we see at endomyocardial biopsy. Nevertheless, it's incredibly important to do typing on this material because treatment is entirely dependent on the protein that's depositing in these instances. For instance, if one identifies light chain type amyloid in the heart, that's going to necessitate initiation of some type of chemotherapeutic intervention because light chain amyloid is the result of an underlying plasma cell neoplasm or plasma cell dyscrasia. Transthyretin amyloid, on the other hand, is actually now the subject of directed small molecule pharmacotherapy. And so there are a number of drugs that are coming on the markets, specifically tafamidis and diflunisal, that are basically small molecule transthyretin stabilizers that get in there and can stop or slow the process of deposition of transthyretin in the heart. In fact, there's some early evidence to suggest that can even hasten some of the regression of amyloid in the heart as well. Serum A amyloid can also be treated with anti-inflammatory because, of course, it's owing to elevated acute phase reactants in a chronic fashion. Nomenclature for amyloid is revisited every 2 years by the International Society of Amyloidosis. Specifically, they gather all the information at their consensus conference, all the data that's occurred in the last 2 years, they revisit it, and they talk about naming schemes and so on and so forth. They just met this last year and updated the nomenclature, so the 2020 nomenclature is out, and I encourage everyone to take a look at it if you have an interest in this topic. The long and short of it is that naming of amyloid is actually pretty simple. The abbreviation for the protein simply has appended to the beginning of it the capital letter A, and that indicates that that protein is in its amyloidogenic form. So the protein abbreviation for light chains is a capital L. If you're indicating that it's depositing as amyloid, it's simply AL. Likewise, ANF, atrial natriuretic factor, the abbreviation is ANF, and to indicate that it's depositing as amyloid, you simply affix a capital A to it, so AANF type amyloid. Now, how do we figure out what type of amyloid we're dealing with? Well, there's a number of indirect methods that can be employed. Perhaps the most widespread or long used is the protein electrophoresis and immunofixation. It has the benefits of being relatively inexpensive, and of course, it's also non-invasive. The problem is the presence of gammopathy does not always correlate with either the amyloid type or even the presence of amyloid. Gammopathy is relatively common in our populations, as we all know. In fact, you can have an M spike in up to 20 to 30% of individuals over the age of 65 in some populations. So that really affects the specificity of protein electrophoresis for typing amyloid. Furthermore, it can only identify AL-type amyloid when it is employed in that regard because, of course, it has no way of discriminating the other types of amyloid. Serum-free light chains, a somewhat newer assay that essentially does the same thing as protein electrophoresis, is also inexpensive and non-invasive and can be done routinely on a blood draw. However, it has some of the same limitations that we talked about with protein electrophoresis, mostly in terms of its specificity. It does have somewhat better performance characteristics depending on where you set the ratio at to make your diagnosis. However, it only is about 90% effective at best in terms of being specific for AL-type amyloid. So there's a whole series of papers out there, and there's far more than even these three, that really attest to the fact that these indirected methods can't be routinely used to identify what type of protein you're dealing with. And as we mentioned, it's really important, it's absolutely critical to know what protein you're dealing with so that you can get the appropriate therapy to those patients. What are the direct methods that are used? Well, immunohistochemistry has a storied history in pathology. It's relatively easy to do. Most pathology labs have the ability to do immunohistochemistry. However, it's limited by the fact that you really have to maintain very large antibody panels to be able to screen for all the different types of amyloid that can be potentially depositing. It's also, for any pathologists out there who have tried reading immunohistochemical stains of amyloid, it is a very, very difficult thing to do. There's often very high background staining. These proteins that deposit as amyloid are often in high proportion in the serum to begin with, and that can create a lot of background staining. And so it's really, really hard, and there's a lot of inter-observer variability with this type of staining. Also, things like antigen masking and variable domains of the light chains can make the sensitivity of immunohistochemistry somewhat poor relative to other methods. And again, lots of literature out here to attest to the high background and the difficulties of immunohistochemistry with typing for typing amyloid. Immunofluorescence, not unlike the relationship of free light chains and protein electrophoresis, has better performance characteristics than immunohistochemistry. It's reliable, the technology is somewhat ubiquitous, with most pathology labs having this at their fingertips, so it's very familiar to pathologists. However, unlike immunohistochemistry, immunofluorescence really is best done on frozen tissue. It can of course be done on paraffin with a series of chemical steps that can remove the paraffin wax. However, that's fraught with lots of background complications and problems as well. Additionally, you must maintain large antibody panels, just like with immunohistochemistry, and also mutations can potentially affect the immunofluorescence staining as well. And so immunofluorescence is limited, even though it is somewhat better than immunohistochemistry. Likewise, immunoelectron microscopy is still better than even immunofluorescence. It's reliable, it's a direct method. It's often viewed as the gold standard for typing amyloid. However, there are very, very few labs that have the technical capabilities to perform immunogold or immunoelectron microscopy. Furthermore, access to EM is somewhat limited in general, and the turnaround time is very lengthy with this. It can take several weeks to do immunoelectron microscopy, at least in places here in the States. So there are newer proteomic methods for direct amyloid typing, and we here at Mayo have been using these for just a little over a decade now, and they've been tremendously successful at typing amyloid in a very efficient, fast, and high volume fashion. These are single assays. They don't require any panels, so they basically enable, you can just put the material into the mass spectrometer, and out comes on the other side a protein signature that tells you exactly what protein you're dealing with. It has been limited in the past by cost, although that cost curve has trended down over the last 3 years to really make it more on par with things like electron microscopy, and even getting close to immunofluorescence in some regards. And the turnaround time has also bent down too. We can turn these around in 3 or 4 days and give good results. The way that it's done is basically you find congophilic tissue in the specimen. You microdissect these out, so we tell the computer where it's going to dissect the tissue. We aim a laser at that tissue, and we capture that congophilic material into a small cuvette or microtube. We then trypsin digest those proteins, put them into the mass spectrometer, and we get on the other end a protein signature. That protein signature is compared to a protein database, and whatever protein is amylogenic, that is in highest proportion in that particular area, we deem to be the offending protein and go after it with one of the targeted therapeutics that we talked about before. The other thing mass spectrometry can give us insights to as to whether or not there are any amino acid changes that might imply there's an underlying genetic mutation in these. And so it can give us some information in terms of the precise genetics in some instances, or at least direct us to where in the gene to be looking for the mutation by virtue of the splice sites we identify in the mass spec. So mass spec can be incredibly useful for this direct typing, and also useful for picking up the mutations. In fact, it's about 92% sensitive. The only mutations we can't pick up are when the mutations don't result in a significant charge or mass change in the protein. So isobaric or synonymous amino acid changes will not be discovered by mass spectrometry. Also, mutations at the tryptic site will also hinder our ability to recognize them. All in all, it's about a little more than 80% sensitive and nearly 100% specific for identifying mutations, whether they're novel or known. It is not, however, sequencing, and so we always recommend that these individuals get sequenced when we identify a potential mutation by way of mass spectrometry. So we've covered a lot of ground here in the last half hour. We've talked about what defines amyloid, how it manifests from both a growth and histologic standpoint. We talked about the types of amyloid, specifically the types that affect the heart and the nomenclature that we use to talk about it. And then how to ferret out what type of amyloid we're dealing with because of the fact that we can see about 8 different types involving the heart. We talked about both direct and indirect methods, but direct methods being more commonly used and more recommended now, specifically because of the directed therapies for amyloid. So some final take-home points here. This is an increasingly recognized cause of heart disease. And in fact, the more we look for it, the more we find it. We think transthyretin amyloid, for instance, is far more common than once thought even 10, 15 years ago, for instance, now. And there'll be some interesting data coming out on that, even at this year's USCAP. Their gross and imaging features can be subtle and nonspecific, so it really underscores the role for endomyocardial biopsy to make a diagnosis of amyloid, even though there are some imaging modalities out there that purport to be quite useful as well, like the PYP scans. Nomenclatures are set by the ISA and reviewed on every 2 years, and that began in 2014 and continues today. 31 recognized types of amyloid that can deposit in human tissues, and distinguishing is important because the therapy is directed by virtue of those proteins. AL, light chain and transthyretin amyloid account for the vast majority of cardiac amyloid. And while AL is the most common, TTR is probably the most common that you're likely to see on biopsy for a variety of reasons that we discussed. The preferred typing method is direct versus indirect, owing to the problems with indirect methods, although immunofluorescence is probably good enough where if you have access to it and you're familiar with it, you could certainly use that and be somewhat reliable. However, most groups, at least here in the States now, are using mass spec. So with that, I'm certainly happy to answer any questions that you have or have any discussion. Thank you very much for your attention.